Hi, my name is Tien Comlekoglu,
My name is Jaihoon Nawzadi.
and we would like to present to you today the utility of electronic and provider-initiated alerts in the diagnosis of sepsis in the emergency department.
So for background, sepsis is a major cause of mortality in the United States. It's a condition for which early identification and diagnosis is paramount for improving patient outcomes in our hospitals. Identifying and alerting for sepsis in the ED commonly involves electronic alerts. So we employ two kinds of alerts to identify sepsis in a patient at the University of Virginia. We have best practice alerts, or BPAs. These are integrated within our EMR system, Epic. It automatically alerts providers of a possible septic patient when 3 out of 4 search criteria are met based on the data that's entered into the patient's EMR. These BPA alerts are pop-up windows that visually notify providers in the ED. A provider may also initiate an alert when they believe a patient is at risk of sepsis based on clinical evaluation and judgment. We call these ED sepsis alerts for the purpose of our study. So in our study, we wanted to examine the accuracy and temporal relation of these alerts at our institution. We decided to identify all BPA and sepsis alert events that have occurred between February 2013 to March of 2019. From these, we stratified the patients into 3 groups. The first group is patients who have received a BPA alert alone. The second group is patients who have received a sepsis alert alone. And the last group is patients who received both a BPA and a sepsis alert. We then examined the accuracy of the BPA and sepsis alerts by determining whether the patients in these categories were ultimately diagnosed with sepsis based on ICD-9 and ICD-10 coding. So in this slide, this is an infographic of our data. There were a total of more than 16,000 patients in our study. As indicated by the yellow group, we identified almost 2,500 total patients who received only ED sepsis alerts. Roughly 1,000 of these were determined to be septic. In the blue group, we identified over 10,000 patients who received only a BPA alert, and over 1,600 of these were ultimately septic. And lastly, in the gray, there were 3,700 patients who received both an ED sepsis alert as well as a BPA alert, and 2,200 of these were ultimately diagnosed as septic.
To summarize, 16% of the patients who had a BPA only were septic. 41% of the patients who received only an ED sepsis alert were determined to be septic, and 59% of the patients who received both alerts were septic. For the BPA and ED sepsis alerts, we calculated sensitivity and specificity values. The BPA alert was more sensitive at 78%, while the ED sepsis alert was more specific at 74%. Now, taking a closer look at the patients who received both ED and BPA alerts, we present a histogram of the frequency of alerts and the time difference in minutes between associated ED and BPA alert events. 58% of these patients received an ED sepsis alert before their BPA alert, and 41% of the patients received an ED sepsis alert after their BPA alert. Although most ED sepsis alerts came before the BPA, we can see the largest frequency of ED alerts came soon after the BPA was fired, suggesting that the BPA does its job in alerting providers to a septic patient. The majority of BPA alerted patients were not ultimately diagnosed with sepsis. BPA alerts also tended to occur after ED sepsis alerts had been activated. However, BPA alerts were more sensitive, while ED sepsis alerts were more specific in identifying sepsis. And because the BPA alert has had a specificity of 12%, which is pretty low, creating more stringent criteria for the BPA alert could be the subject of future studies. For patients who received both ED and BPA alerts, the highest frequency of ED sepsis alerts came soon after the BPA was fired, and this data was pulled from the histogram that we showed earlier. In future studies, we would like to further investigate how BPA alerts influence provider action towards potentially septic patients. Finally, we would like to acknowledge the University of Virginia Department of Emergency Medicine and the School of Medicine at the University of Virginia for supporting us on this work. We would also like to sincerely thank our data analyst, Hissam, for making all this work possible.
Okay.